All right, well, welcome. I'm going to go ahead and get this kicked off. We might have some more people joining us throughout the hour. Just as a reminder to everybody on our panel, as well as everybody in our virtual audience, this event is recorded and will be posted on the CWD Screenside Chat website at cwd.is/screenside. So if you have a question, feel free to pop it in the chat. We may get to it during our program or we may get to it at the end. And if we don't, feel free to submit your question through the CWD website. We might be able to point you in the right direction or at least get you in contact with who you need to speak with. So once again, thanks for joining us here tonight. My name is Matt Point, and I am the Director of Advancement here at Children with Diabetes. I want to introduce you to a few of our panelists we have with us tonight. And first, I want to chat with, welcome Dr. Mary Pat Gallagher.
Hi, thank you so much. It's very nice to be here with you. I'm the director of the Pediatric Diabetes Center at Hassenfeld Children's Hospital at NYU Langone. And again, thank you for having me.
Thanks for being here. And next up, we have Chris Lally. Chris.
Hi, thanks for inviting me today. I'm honored to be here. My name is Chris Lally. I'm a nurse, CDE, and the school education specialist. I work with Dr. Gallagher at NYU Pediatric Diabetes Center.
Thanks for being here, Chris. And last but not least, we have Tanya and Brian Morris. Hello, welcome.
Hello, thank you so much for including us. So we are parents of a type 1 diabetic child, and we are thrilled to be able to participate tonight.
Awesome. Well, thanks for being here and thanks for joining us here tonight. So tonight we will be speaking about a very important topic, which is advocacy, especially as we think about going back to school. It's August 1st, which means school is right around the corner. I know it starts this week in North Carolina in some places and throughout the rest of the month and into September. So I'm really excited, for everybody to get back to school and for life to start, hopefully getting back to a little bit more normal here soon. But thanks for joining us tonight. Tonight's topic is getting ready for back to school, the powerful partnership between parents, doctors, nurses for advocacy, plans, and Glucagon. So we're here tonight to discuss what we can do to best advocate for our students and children living with type 1 when they head back off to school with type 1, or maybe it's their first time heading off to school with type 1, or it's their first time back to school in a long time with type 1 in the post-pandemic world. So just as a reminder, tonight's event is recorded. If you have any questions, feel free to pop them into the chat to us, or you can ask through the Q&A. If the question is applicable to what we're discussing at the time, we may add it into our current conversation, or we may ask it at the end. So feel free to pop it in the chat or shoot us a message in the Q&A if you have any questions. All right, and with that said, I think we're going to go ahead and get started. So first, I'd like to talk to Brian and Tanya. And I'd like to hear you share some of your experience in navigating the school with a parent, as a parent of a child with diabetes. What's been your biggest learning issue? What's been your biggest realization in that process?
Pick it up. Okay.
I say he goes first, he say I go first. So our child was diagnosed 3 years ago, and over the summertime, in fact. So going back to school was our first big thing that we had to really navigate and figure out how to navigate. So in time, we've learned a lot of things, and some of our best practice learnings really is to just get in early with your child's school and figure out, will they need a para? Are they going to be able to self-manage? Just really how to navigate what will be best for that child and support them with the appropriate team around them to be able to be as engaged in school as possible and not have the diabetes really be the primary focus. What would you add?
Yeah, I would just sort of add to that, echo what Tanya said. Also it's sort of a lengthy process, one in which you maybe start at the beginning or right before a school year begins. And you really need to kind of get in and develop a really, really strong partnership. I think that's the kind of, tonight's theme between the medical team, the endocrinology and the nurse diabetes educators, as well as all the various members of the school staff, anyone who really comes into contact with your child on a daily basis, you kind of want to be on a first name basis with. And in any process, you may not get everything that you're looking for on the first day. So, don't necessarily be discouraged by that, and really try to formulate, a long-term relationship for that year with all the folks that you're encountering. And I think anything that you can do to help promote that, I think one of the things for us where we noticed a significant tipping point was actually Tanya had volunteered, separate and having nothing whatsoever to do with type 1 diabetes, to actually join the executive board of the school's PTA. And when many of the staff and administration saw that contribution, I think that just helped kind of put a lot of the asks that we were shooting for into a sense of perspective, and made the folks more willing to kind of hear us out, when understandably the school's in a real triage mode and has a lot of competing needs and demands on school administration as well as teachers' time. So I think those are probably the highlights for us.
And that was in a non-COVID year. So with COVID on top of everything else, I think it's just hugely important to really form that partnership and form those bonds, and also try and be as prepared as possible for something that is kind of unforeseen. So you have to plan ahead for what you don't really know is coming at your way.
Yeah, very, very much so. Thank you. Do either of our HCPs have any thoughts on what their experience has been like working with school districts, or navigating the school experience for students with type 1?
Yes, I'll go first, just because I think that Chris has probably a lot more to say and a lot more meat and face-to-face time with the people at the schools. But I think big picture wise, what I've learned over the years is how much of an opportunity there is to be able to educate everybody who's going to be interacting with your children in the school. They spend so much time there. It's sort of the equivalent of your job. And so we want the people there to really understand what it is that we're asking of the child, and or adolescent, young adult, even as they go off to college, and the impact that these adults can have on how these children and young adults will approach their diabetes management is really significant. So it's really the supportive role that they can play is a critical role. And I think just letting them know that they may not be aware of that, of how important their roles can be. And now I'll let Chris go. Oh, you're on mute.
Sorry. Forming that partnership between families, school nurses, if there is a school nurse, and school staff, teachers, is crucial, vital to the student's outcome, for just a nourishing school day and providing a safe environment at school. It's our goal to allow these students to participate in the entire school day and be able to care for or have their diabetes cared for in their usual school setting. And how do we do that? And what does that look like for your child? It's very individual. I find when I reach out to schools, speak to families first, and go ahead and insert myself into that program, and we develop a whole team together, the outcomes are very productive. And it is ongoing, as Tanya said. This evolves throughout the school year, and then it should be reevaluated every year. Is there a nurse? Do we have a 504 DMAF school orders in place? If there's not a nurse, if it's a private school, who's going to be our team to help this child flourish in school and be safe? So I do find the face-to-face, last year mostly virtual. Education is productive, and we invite families and students to be involved in the education. I invite them to the schools for the education and on the virtual chats. I find that that experience really develops a clear line of communication between families, schools, and myself. And we're all on the same page, and it's a positive experience.
Awesome. Well, thank you. Yeah, I do think that's really an important thing to say is, having those relationships with the school community really makes a difference for everybody involved. It's easier to get your question answered if they know who you are when you're giving them a call, and you're not a generic name over the phone. Brian and Tanya, I have a question for you. Can you tell us what your approach has been like, or if you have any recommendations for advocating for your student to ensure that they're still having a successful learning experience while managing their diabetes in school?
Take that one.
So I think it's really important to know your child first and understand what's going to be important to them and how are they going to want to have diabetes managed in the school environment, in the school setting. Are they comfortable if they need to check their blood sugar in the classroom, or do they prefer to go to the nurse? For our son, he really wanted to be able to do everything on site and not have to travel, especially if being treated for a low, for example. But it's important to know your child and know how they feel most comfortable and where they're going to feel the safest. For us, it was really important to make sure that whomever was going to be interacting with our child knew what was going on, knew that they needed to have, he needed to have access to his cell phone, for example, and he would be able to send us a text message if he had a question about how to deliver insulin for a meal or a snack in the classroom. If he went low on the playground, the nurse, would go out and find him on the playground and treat in place. But for other children, it may not be that way. Initially, when our son was diagnosed, he did have a para, and then he realized that the para wasn't really helping him that much, just really kind of carrying his stuff around. And initially, he was being bolused in the nurse's office, and then he felt more comfortable having lunch in the nurse's office, which is not the healthiest environment. If you're a healthy child who just needs insulin, he got exposed to a lot of germs, and he got really sick the first year he was diagnosed. But we had to have some sort of a migration path out of the nurse's office and to have treatment be able to be done in place. That's just one aspect of some advocacy. Also developing a relationship and a rapport with the teacher so that they could have kind of like a silent communication. If he felt like he was going low in the classroom, he could just, give a thumbs up like, I'm all right, or thumbs down. But those kinds of things need to really be developed between the child and the teaching team, as well as the nurses team as well.
Yep, that sounds great. And I guess what I would add to that, consistent with what we talked about in the beginning about the partnership, it does really take all angles, both from the healthcare side of things as well as from the parent side to really work together. So, invariably, if things maybe look like they're not going sort of according to plan, to try to kind of troubleshoot the situation and figure out what the best entry point is and how to really, are you going to raise it with an administrator? Are you going to talk to a teacher? Is your diabetes nurse educator like Chris going to lob a phone call into the nurse just to kind of find out how things are going? It really does take that comprehensive approach, as well as working really closely with like your child to find out, hey, how did it go today? How did you feel about what went on, or what can we do to help support you? And frankly, in that process, we are, kind of modeling really good behavior. So there'll be a point in time where students will have to step outside and they may not have their parents right there at their side. And I think for us, it was a little bit about trying to model those behaviors, about how to engage and how to, it's our child has become very, very persuasive when it comes to his own management and his diabetes, from this experience. So I think the sort of holistic approach and focusing largely on the child and working together really as a team is the best way to drive the results that everyone is looking for.
And I would love to add one more thing. As I hear everybody saying things, I have all these thoughts and agree with what everyone has said. And it just made me want to add one thing, is that no one way of managing things, there's no one size fits all. And so when Tanya was mentioning, you have to see what your child's comfortable with. So as a pediatric diabetes specialist, I want the child to be comfortable doing everything in the classroom. I don't want, or the playground or wherever they are. It's very important for me to try to help them get comfortable having their diabetes management be part of their life and not separate from their friends. Because as they get older, if you have to choose between diabetes and friends when you're an adolescent, a normal adolescent brain will choose friends. So we don't want them to have to make that choice. But having said that, just because that's what I want for them doesn't mean that's where they are when they're diagnosed at the age of 11 in middle school. And it can be very, very difficult to be different at that age. So even though I know that's my goal, we work with the nurse and the school and the child and the parents and everyone together, hoping we can get there, but we don't have to be there right this minute. I think it's just important to recognize that it's a journey.
Agreed. And I think Brian made a great point of asking what, how is this for you? And, really hearing from the student and your child, they know best what's working for them or what's not. And make sure, we're listening to their voice. Quick question for you, Tanya, as a follow-up to a note I received. Can you tell us what a para is and how you went about getting one?
Sure. A para is otherwise known as a paraprofessional, someone who can support your child in the classroom setting or throughout the school. It can be set up with help from your doctor, and each school goes about assigning a para in a different way. So it's basically like a helper person that is everywhere where your child is, helping with dosing insulin initially, before meals, or monitoring activity at gym class. So the para just follows your child throughout the school day and serves as a help. I think I would pass it on to Chris to embellish a little bit more. You're on mute, Chris.
Yeah, paraprofessionals are hired by the school. Typically in New York City, students and public school systems are provided paraprofessionals up to the age of second grade. And they are specifically trained to care for your child with diabetes. They will carry the supplies around, treat lows in the classroom, provide activity treatment based on the orders from the physician. They will also, our paras are now trained to give glucagon, and the training process can either come from the school nurse or myself for our patients. I train lots of paras throughout the school year. And then slowly towards the end of second grade, I'll also meet with the paras again to teach them how to start transitioning those students who are going to be entering third grade and no longer have that para. So sort of take a step back and have the child do a little more active management, also in coordination with the nurse. So it's a very nice thing. Other schools that maybe are not New York City public schools, they call this one-to-one professionals. Sometimes it's the teacher assistant. They'll have two teachers assistants in the classroom, and one will be the acting sort of paraprofessional.
And a little bit of a follow-up to that question, Chris. Can I advocate for my child to have a one-on-one nurse if there's no nurse in the preschool setting?
So yes, you can. And this is all part of the school orders. So the DMAF 504 and school orders that come from your doctor, they get turned into to the Department of Health, Department of Education, and then we wait for approval for that. So I do have private schools who do not have a nurse, where a nurse and a paraprofessional get approved. Now, providing that, there's a lot of work that needs to be done to see how is this going to come about and how is this going to get approved. I suggest please talk to your diabetes care team and your school district about this to find out how to navigate that path. And then Brian, you may have some insight into this as well.
Sure, that makes sense. I would just sort of add that, I think we're dealing with folks all over the United States that I think are dialed in today. So the sort of how different states and different municipalities, different communities, and I think the question actually came from a regard to a preschool program. So I'm not sure whether that was a private preschool or a pre-K as part of a public education program. So there's lots of different sort of pathways forward in order to try to get essentially what we're talking about is a reasonable accommodation to allow the requisite support to be given to the child, who's most likely going to be, if they're in pre-K, not at an age where they're yet comfortable monitoring their blood sugar and basically handling diabetes management tasks, and need some additional oversight in order to sort of do that. So I think, as Chris, as you mentioned, sort of engaging with the diabetes care team to just kind of find out in your local community what folks have been able to get, and in addition, also connecting with other parents in that community of students. If you can kind of get in touch, I know there's a number of boards out there on Facebook and other social media to try to find out in your state and in your area, what accommodations have been routinely granted and which ones may have been somewhat of a heavier lift, and kind of sort of navigate the process that way.
Yes. So I just dropped a link into the chat for everyone. It's a resource from the Children with Diabetes website called Diabetes in School. One of the sections on there is on legal rights within schools and 504 plans. So it talks about all the different types of schools and the types of accommodations that you can request and work through. So I would highly recommend you check that out if you have any questions on that area. Moving on to our next question, similar to the one I just asked to Brian and Tanya, but I'd like to ask our HCPs here. How do you partner and engage in these efforts to ensure that patients and caregivers are prepared for incorporating diabetes management into the school day? What do you recommend and what do you do?
I think that I will defer to Chris because I think he does the majority. I think that I am really fortunate to work with a team that's able to be supportive. And so from my perspective, I think that my goal is just to be clear in my communication that while safety at school is clearly, necessary, that's a pretty low bar. And we want our children to flourish at school. And so that's really our expectation, and that it's possible and that it will take work. And as Tanya and Brian said, it'll be a journey and you'll have to keep working at it. It won't be perfect immediately, that is what to expect. And so trying to just help them set expectations. I think sometimes people may be willing to accept if a school erroneously tells them a child can't check their blood sugar in a classroom. Well, they may just take that as a no. I've had families tell me, well, they're not allowed. And so just that you should know that the first answer might not be the last answer, and to continue to explore what's possible. And really it's Chris who will be able to give a more specific answer.
And this is where,
take it away,
so
Chris.
I'm a CDE, so I meet the patients at diagnosis, and this conversation starts at diagnosis. I get them thinking about school, even preschoolers or daycare. Where do you go? Where can we meet your child, and what needs to be done to keep them safe throughout their day? So I talk to parents first, then reach out to schools, and then get into schools with school education, offer myself as a support to the schools, develop a relationship with the schools. And like Dr. K. Gallagher said, some of the answers, some of the expectations the school has, their anticipations might not be the first answer you want to hear, but then collaboration, meeting with them, education, and forming that whole relationship works. So, and will work ultimately for the child. So it's getting into schools, having the school orders set. If there is not a nurse at school, finding out who's going to be that team, who's going to give the insulin, who's going to treat lows in the classroom, or wherever this child is going to be, both inside school and on field trips. So going through all these little details with the school, with the parents, with the student, through education and support. I find very beneficial. So I highly recommend to you all to reach out to your diabetes care team, reach out to your CDEs, your endocrinologist, and the school. Try to have that meeting before school starts. Very important. My goal is to get there with the student and or before the student goes back to school, to start that education process. And have that 504 meeting at least annually. You want to revisit that as needed. Go through the accommodation list with the student. Let the student pick, and you pick what accommodations are necessary according to their age and independence level. And let that 504 plan, which is part of their whole, in their school system, let it grow with the student throughout their life, and then into college accommodations also.
If I could just add something to that. I think it's also really important to get with the school and understand what will that child's school schedule look like. Mm-hmm. Will there be recess before lunch or after lunch, or will that come close to a gym class? We had to make all sorts of accommodations and logistical gymnastics just to be able to support our child in navigating the day when it was going to be gym class, then lunch, then recess, and with the insulin up and down. So it's really important to really understand, like, what's the day going to be looking like, and how can that child be best supported with all of those fluctuations in insulin needs and activity levels, etc.
And also recognizing to that, that on top of it, oftentimes schedules do change at the last minute. And so there could be a schedule change. So it's something that you kind of have to anticipate and, talk to your child about, hey, things may not go as according to plan, but we're going to just kind of figure out a way, and you let the nurse know, or you let your para know, and we'll try to work it out and try to sort of, iron out those wrinkles when they come, because just the way that schools operate, things change. So just to kind of anticipate that it's not, things are not going to always move along in a straight line.
And there's a lot of education that has to happen, because unless you live with diabetes day to day like we do, and like our care team does, the teachers don't really understand the impact of the decisions on that schedule.
Mm-hmm.
Yeah, I'll add to that. I tell schools that, our families plan the beginning of the school day as soon as that child wakes up based on the schedule for that school day. Their insulin requirements for breakfast may change if they go straight to gym class in the morning or they have an early recess. So it is important to go through that schedule. I usually sit down with nurses and families and we go through the entire week schedule, but then also communication. One contact person or two that are in constant communication with families. So if the schedule changes, the families know ahead of time so they can try to change their plan for the school day too.
Thank you. On a similar topic about preparing, Brian and Tanya, what lessons have you learned in ensuring that your child's hypoglycemia treatment plan is implemented in the school environment? And to that end, what should other parents know or consider when they're making that plan?
Sure, I'm happy to kick that off. So I think with respect to hypoglycemia, I think we're sort of kind of maybe talking about two buckets. The sort of how to treat and be prepared for mild hypoglycemia, which obviously can happen, diabetes sort of at any time, and understanding how that's going to be handled, and making sure that everyone who's in contact with your child is aware of what could happen relative to mild hypoglycemic events, and sort of what needs to be done. Our personal experience, initially was that I think our child was kind of asked to, walk down a couple of flights of stairs to the nurse's office just to take a glucose tab. But obviously that wasn't, there wasn't any sort of ill will or anything like that going on. It was really just more an educational process to say, hey, this is something that whereas most functions in the nurse's office are handled in the nurse's office, this is something, and explain the reasons why it's important to treat in place, and have a communication line between the classroom and the nurse's office, so that the nurse could sort of approve at that time when our child was not self-managing. Okay, 1 tab or 2 tab or whatever the DMAF orders say is the appropriate treatment for those mild hypoglycemic events. So that's obviously a process that needs to be worked out and gone through, so that everyone's on the same page. When it comes to more severe hypoglycemia, and for that I mean something in which everyone would need to be prepared to understand what glucagon is, how it needs to be prepared or delivered, whether it be some of the traditional glucagon preparation kits that were widely available, or some of the new forms in terms of the nasal administration or the pre-mixed glucagon. Just understanding what this is and how it is used, what are the signs and symptoms that need to be looked out for of severe hypoglycemia, and then in order to make sure that everyone who is in touch with your child, there's a plan in place, who is going to be the one to be trained. And frankly, and a lot of it may wind up turning out to be sort of a little bit more self-service than you would anticipate, in terms of, I know for our experience, one of the challenges in getting everybody trained was just to be able to get those test kits, the sample kits, in the hands so that the school nurse could do the training. And so we had to kind of do some recognizance of our own, and reach out to the someone in the school, in the sort of central office, to make sure that those kits got to the nurse's office so that she could perform the training. And frankly, I'll just be honest with you, all the staff was totally welcome to participate in the training, was aware, and was very positively received. But it did take a little bit of maneuvering in order to get those pieces in place. So I think those are sort of the two sides, and obviously to the extent that that's memorialized in your annual 504 plan, or informal 504 type meeting to understand what this is, how it needs to be treated, and the different sort of options involved. I think it's just, probably a little bit about how we approached it. And then, that's obviously something you have to think about every year annually, as there'll be new teachers and children progress year after year into different grades. But once you've done this a couple of times, then you kind of have a lot of the tools at your disposal, and you can make for a much more efficient process.
I think it's very important, especially for newly diagnosed families who may not really understand how to navigate all of this, to really rely on your diabetes care team and those educators. We had no idea that in order to administer glucagon, a teacher needed to volunteer to be trained. It wasn't an automatic thing. I just figured, oh, there's the teacher, they're going to be in the classroom with my child. If anything happens, like a lockdown scenario, for example, I need my child to be able to get that glucagon delivered by whomever is next to them. The teachers, of course, would volunteer, but I didn't know that. So I think a lot of times you need to just really educate yourself so that you can figure out how to best navigate that situation for your child and advocate for your child. Also to make sure that there's glucagon everywhere and anywhere it could be. So our child has chosen to wear like a pack with just the essentials on his person. It's like a cross body bag pouch, and he's got his cell phone in there. He's got his low treatments in there. He's got a glucagon in there, and a meter, a test meter. It's just important to make sure that something is always with that child. And then there could be backups in the nurse's office. There could be backups in the backpack, for example, but always to make sure that there's something readily available on the child.
Thank you. Dr. Gallagher, to speak a little bit about glucagon, can you tell us a little bit about what the options currently are? I mean,
Sure.
Brian just mentioned a few, so it might be helpful for all the folks joining us today to know what their options are when they're out speaking to their team or to the school district to see what might be best in their situation.
Sure. Until very recently, the only option for glucagon administration was a powder that had to be mixed with a solution that came with it. So there was water and the powder, and the person would have to mix it up immediately before administering it. And in that time, it's an anxiety producing moment anyway, right? So you typically use glucagon only if you're unable to treat a low blood sugar by mouth, meaning for some reason, either the child is unconscious or vomiting profusely, you are unable to give juice, right? So now you turn to glucagon. So typically that's what people have been trained to do. And it's a kit that comes usually in a bright red or orange kit. And that's traditionally what people have used. In the past year or two, we've had 2 new types of glucagon that have been approved by the FDA. Not all insurances cover them, but there's 2 different kinds. One is a nasal powder. So even if the person's unconscious, they don't need to inhale it forcefully. You can just put that into the nares, into the nasal passage, right? Into the nostril, and you push, and a relatively large dose of glucagon, because it is going to be kind of passively absorbed, is given and works pretty much as well as that old kit. And it's much easier to do. So that's great. And then another version, and subsequently another version of pre-mixed glucagon. So there's none of this taking fluid from one place and putting it into the powder and then mixing it and then drawing it up again. They have pre-mixed glucagon, and that's just many fewer steps. And one is in a type of pen administering device that's very similar to an EpiPen. And so for a lot of school personnel and family friends, that's much less frightening because they're familiar with EpiPens and it works much the same way. So those are great options. Again, they're not necessarily covered by everyone's insurance yet, but they all work. And I think a very important thing is just to not be afraid of glucagon and to try to teach everyone who you are teaching about glucagon that nothing terrible will happen if you give glucagon. It doesn't make the situation worse. It will make the blood sugar rise, which is mostly what we want. And even if you're not 100% sure that it's required, it'll just make the blood sugar rise. Sometimes kids will get nauseated and vomit, but these are things we can manage. So trying to decrease that fear. If you think that the child needs it, then you can administer it. It's like an insulin antidote.
Thank you. And for anybody who's interested, I did drop a children with diabetes resource about glucagon into the chat. It explains what the different options are out there. And as Dr. Gallagher said, not all of them are covered by insurance, but it also includes information on how you can get help assistance paying for those options as well. So if that's something you're interested in, please check them out on that resource tab I just dropped into the chat. So my next question is actually for Dr. Gallagher and Chris. And I'm curious, what lessons or insights have you gained from partnering with parents in this process to ensure that treatment plans are known and are implemented within the school setting, whether that's in the K-12 setting or in the higher education setting? What have you learned, or what insights do you have from working with parents on, for these plans to get implemented?
So I've been talking a lot, Chris. I'm going to let you start with this one.
So working with parents is very beneficial, and working with students themselves too. These students know their specific low symptoms, what comes on first for them, how they feel when they're low, and how they want to take care of their low in the classroom. And it depends on the student too, how much of a treatment they need. Not all students need your typical 15-gram juice box to treat a low blood sugar. And it also depends on what that number is. So yes, the school staff needs orders in writing, but working with the families to write those orders specifically. Is it 5 grams for a blood sugar range, 10 grams, and when and where to treat is really important. And what are that student's specific symptoms of a low blood sugar? If it's a 6-year-old who can identify those lows and says, I feel wobbly, great. So it's great being on a chat or in an in-person meeting with families and school staff, because they get to hear that directly from the student and the family. And then they can also develop that rapport with that student. So it is very important to develop that relationship.
Yeah, I think that's, exactly right. And I think we have to recognize that every individual's experience is unique. People don't have exactly the same experience just because they have the same type of diabetes. And every child is different and unique as a human being. And I think that for me, one of the things I've learned from trying to listen to families and children is how important it is to just support them in their journey from where they are. So I referenced earlier that I want everyone to be comfortable doing everything in front of everyone, and recognizing that's not realistic immediately for most people. But that you need to hear what is working for them and what's not working for them, and try to support them and help them to further what they think would be best for their child.
And I'd like to add that I find that through education with families and school staff, diabetes is normal for these children. This is their normal. It's their everyday life. It's normal in schools, and we can't prevent all lows. A low is going to happen during the school day at some point in time. It shouldn't happen every day at the same time every day. That's when you need to reach out to parents and or myself, Dr. Gallagher, your diabetes team. But this is going to happen, and how can we normalize this and provide safe treatment for the child and still let them continue their school days safely?
Yep, thank you. Just out of curiosity, and this is for everyone, has anybody found a change in the discussion when working with school districts since the now that the ready-to-use treatment, ready-to-use glucagons, or the stable versions are available for prescription?
Sure. I think we've probably all had that experience. And again, depending on where you live in the country and how your school system is set up, this may or may not be such a significant issue for you. But no one could have ever foreseen when they were writing some of the statutes that glucagon would be administered in any way other than as an injection. So some of the statutes are written that non-licensed personnel can give injections of glucagon. Well, what about intranasal glucagon? So there are little things like that, but they're not insurmountable and they're being addressed, but there are definitely things that have come up. And then for Chris, I'm sure you can talk a lot more about how you have altered your education depending on what type of glucagon families are sending to school with their children.
So yeah, and some of our families have several types of glucagon that they are sending to school with the children. And it just depends on the scenario at the time. You know, if there's an adult coach that's willing to step up to be trained in the nasal glucagon and they have the ability to have that one, that's the one I'm going to teach the coach. I find that I end up teaching all three no matter what, because insurance ultimately a lot of times is going to drive which glucagon is going to be covered, and that could actually change at any time. So having knowledge of all types of glucagon is super beneficial. And I do find that, you know, and Brian had mentioned this too, the use of the demo kits in the schools for the nurses to actually go out and train the staff is really helpful. So if I train the nurse on all three and then can get them those demo kits, then they can go into schools and for all of their school staff and train their school staff on how to do that, because lay people and adults are now allowed to be trained on glucagon administration.
And just to share a little bit kind of from our experience as well, you know, I think that just a little tip on the advocacy side, just because you get a denial from your insurance carrier for a particular type of glucagon, don't necessarily take that as the final answer. There oftentimes is an appeal process, and I think we actually made use of that to have your, you know, in our case, Dr. Gallagher had written a letter explaining why we needed to kind of be able to ask for one of the newer versions that didn't require the mixing, given the age of our child, and we're able to get an approval before the drug was actually on the pharmacy formulary for our insurance plan. So again, it was a little bit of paperwork to get that through, but eventually it did get covered. And I think in our case, it did get added to the formulary. But you know, the road is not over then. Then you have to kind of take that new product when you get it and kind of I remember going back into the school and, you know, asking to have a meeting with a nurse, and she kind of looked at it and said, well, what's that? And I kind of explained that to her, and she was, you know, a little bit confused at first about, well, what do you mean? I thought I have to do the mixing. I've done the mixing my whole career. You're saying I don't have to do that anymore? And so again, and then that had to get rolled out. So you are, you know, it is a process. And so, you know, just be sort of prepared to, you know, kind of take it from step 1 to 2 all the way down. And then eventually you're at a point where everyone is aware of the new optionality that you have.
If I may, just Chris mentioned about the coach. So we've been doing a lot of talking about what happens in the classroom, what happens at school, but coverage for your child doesn't end and start just in the school. So for class trips, our son was on the track team for track practices and track meets. There's such a thing as a field trip nurse that you can request. So you really need to make sure that there's coverage no matter where your child is, and your child should not be denied access to participating in those class trips or participating in those track meets because there isn't a trip nurse available. In some cases you may have to go, or your babysitter or some other caregiver may have to go, but we always tried our best to make sure that our child wasn't really denied access to anything as a result of having type 1.
Thank you. So this question is for Brian and Tanya, and I'm curious what advice you might have for preparing and engaging with your child and your school community.
We've been saying it again and again. So early access is really important. Understanding your child and what their needs are and what their personality is like to figure out what's going to really work best for them. Getting that advocacy and coaching from your diabetes educator and doctor team, I think is really, really important. And being prepared, like just trying your best to be prepared for every scenario. We used to have like snacks that were, you know, pre-nutrition fact labeled snacks that always available in the classroom, because it's going to be somebody's birthday party and maybe the parent won't know how to, take a guess at the carb count on a cupcake or a slice of cake when they used to have parties and celebrations in the classroom. Think about no one will ever be blowing candles out on a big cake again since COVID.
Yeah.
But we always used to just make sure that we had something on the ready for our child to be able to participate in celebrations during the school day, and preparing like a shoebox that had all sorts of, low treatments and snacks and the glucagon and, glucose tabs or whatever really would be required. It's always important to make sure that your child has on their person what they're going to really need access to, but having backup materials in the classroom and with the nurse, I think is also really, really important. And just forming that partnership and really getting in early with the teacher team and the administration and whomever really kind of needs to get on board that train, because it's going. And you need to really be prepared early. Do you want to talk about like the beginning of the school year?
Yeah, I mean, I would just sort of also add that schools by their very nature are institutions with sets of rules associated with them, right? And so just a perfect example, since our child was diagnosed over the summertime in a big school district like in New York City, my understanding, what I came to learn, that the teachers' contracts that are negotiated and the product of lengthy labor negotiations require them to be present essentially the day before school and understandably not necessarily a day earlier. So we kind of found ourselves in the school with nurse's office on the day before school. And you can imagine what that school looks like the day before school when all the teachers are getting all their rooms ready and figuring out what they need to do. And then obviously everything we've talked about in the last hour or so, we could probably go on talking about for many, many hours and really have a lifelong amount of learning surrounding. So that obviously was the first day. But so to the extent that folks are available earlier in the summer, then sure, it makes sense to go in there, but you may have to, I guess, plan a little bit for a lighter schedule. Look, and not everybody has the flexibility to take time off work or to arrange for coverage, but to the extent you can have someone available. I know when it came down to our process in our school, we weren't able to actually get the orders from the endocrinology orders approved through the central office of the Department of Education and into the nurse's office to allow the nurse to deliver insulin for a couple of weeks. And we actually had to wind up taking a trip and hunting down that central office and getting in front of the right people to kind of break a little bit of a logjam there. And once we got in front of the right people, we were not only able to get our child's orders approved, but another child's orders in the school, another child with type 1 diabetes who was in the same position of having their parents have to be at school to do the insulin dosing because the bureaucracy hadn't really kind of caught up. So yeah, I guess just kind of to the extent that you're dealing with this situation for the first time heading into the school, you might want to see if there's anything you could do to perhaps plan for a little bit lighter schedule those first week or two of school until you can kind of get things ironed out, recognizing that there are, understandably as a parent, this is a scary situation, turning your newly diagnosed child over to the care of others when you may just be learning a lot about this, for yourself. So it kind of takes some real versatility, I say, in really trying to particularly in the beginning, and as things go on from year to year, it's been a little bit smoother road each year for us. So that's what some things that I would recommend keeping into account, particularly as you were in this realm. And I think we haven't really talked about it much this call, but obviously we're in a situation with COVID-19 where the situation is dynamic and fluid and changing all over the country. So having some flexibility in understanding what school is going to exactly look like, and understanding that all the school teams are faced with these inordinate challenges at the same time that we're going to be in a position to really be making requests and asking, to the extent that you can kind of go in there with that sensitivity in mind to understand, I know everything that you all are doing. This is tremendous. I have a few things that I'd like to kind of ask of you. And so it does become a recurrent theme where you're kind of going back and back to try to course correct as you go. But kind of keep trying to create a positive working relationship with everybody involved in the child's care, I think goes a long way.
Perfect, thank you. And you actually brought up my last topic. So my last question is for Dr. Gallagher and Chris, and it is, do you have any last recommendations for parents as they prepare for their child to return to school and to implement their first or potentially update plans for the school year. As you know, some people have been out of school and haven't been in in-person school since March 2020. Some people have been in school, some people are first time to school with type 1. And then in addition to that, a question we received through the chat was, are there any new guidelines for COVID that you'd also recommend when you're having these discussions?
Yeah, those are really great questions, and we could talk another hour about those too alone. But I'll start by saying that I agree with everything that Tanya and Brian have said. And I think a positive attitude, I think you should always assume that the people in the school want to do the best for your child, because most 99.9% of the time that's the case. And having open, honest communication is going to go a long way. And just education, education, education. And even though newly diagnosed children and their families might be in the most difficult position, some people have been diagnosed for over a year and a half, and this might be their first time going to school because of COVID. And so they might have been homeschooled. And I have actually seen a few people who are hesitant to let their child go back to school because they haven't yet been to school with diabetes and they've had diabetes a year and a half. So there's a lot of fear and emotion, and it's totally understandable. And what I've always told people is there's no one right answer. As I said earlier, this is true for COVID also. You need to think about your child. Do they have other health conditions? Does anyone else in your household have any other health conditions that places them at very high risk? What is the COVID positivity rate in your area? What are things looking like? These things all need to be taken into consideration when you're making a decision about what special precautions you should be taking for your child. Yes, and Chris, you probably have some more specific things you might add.
And right now, Dr. Gallagher, you'll agree, our guidelines, and we are recommending that our students and all school staff do wear a mask in the school setting. And as of right now, New York City is saying that they are planning on opening in-person learning in September. So things are forever changing. And I remember saying this when COVID first hit and we first closed. Every day things are changing. So, be open to be flexible with that change. And as hard as that is, because, parents are working and students are, remote learning, hybrid learning, in-class learning, and we don't know what's happening from day to day. Try to be flexible with that situation and talk to your care team provider, talk to your endocrinologist, and then also the school, reach out to the school. Tanya and Brian mentioned some very key points, what do you need in school to keep your child safe, and meet with them, have orders in place to keep your child safe as well, and reach out to us if you need us.
And I want to add, sorry. I just want to add that I do believe currently that the vast majority of children with type 1 diabetes are totally safe to go to school. I do recommend, as the American Academy of Pediatrics does, that everybody wear a mask in school. Vaccinated, unvaccinated, doesn't matter. Everybody should be masking up in school. But I just wanted to point out that everybody has to consider their own circumstances. And it is a constantly evolving situation. So thank you.
So that's it for my questions. Does anybody have any final comments or insight or any recommendations they wish to share?
Sure, I could actually have some final thoughts. Obviously, thank you so much for this opportunity to chat this evening. It's really been a real privilege.
Thank you for joining us.
For both of us. One thing we focused a lot of our efforts and energy today on the child, but I don't want to also leave out the fact that all the parents and the caregivers who are dialed in, who we don't necessarily see right now, this is obviously no doubt a burden, a significant burden to bear for everyone. And so I would really encourage, something that was really helpful for us was to kind of reach out and connect with other parents and caregivers who are in similar situations, who have kids, because I think, as Tanya had mentioned, it's only sort of our family here who really kind of gets this and really understands it at a core. Everyone else is sort of an outsider that we're really trying to kind of help educate and kind of bring up to speed. So as you go on that journey, the fact that you can engage with other folks and learn from them and kind of get some additional support in being successful on the challenges that we're invariably going to face and push through. I think that would be that is certainly very helpful for us to do.
Yeah.
So I definitely recommend getting in touch with other parents, regardless of where they are, other parts of the country, just so that we're all sort of in the same boat together.
Yeah, and diabetes is such a complex disease to manage that between the two of us, we kind of had to divide and conquer. So my area has been food and beverage mostly. Brian handles a lot of the ordering of the supplies, and we both, have to kind of team up on a lot. But it was remarkable to be able to engage with some of the Facebook groups, and I know CWD offers a lot of support to families. In the beginning, you're really in learning mode, but then, we're 3 years into this journey now. It feels good to be able to be in a position to actually know some things and be able to share our knowledge and from our experiences with other families who are newly diagnosed and kind of like pay it forward type of thing, to be able to really like learn by having, encountered all sorts of different scenarios. And I remember there was like a tipping point when we gave a very large bolus for a meal, and I suddenly finally had the confidence where I knew that I'd be able to handle whatever happened. And it takes a while to really get comfortable with that. But I think it's really important to, as Brian mentioned, have other people that you can kind of rely on and like ask questions to in the moment. We've got like a little text chat group going with a number of other families, but it is important to feel like you're not alone in this.
Yeah, I'd like to just say that I've been so moved by the families who've shared with us how they have experienced going through this, having a child diagnosed with diabetes. And uniformly, a few years in, everyone says that it was so beneficial to connect with other families who've gone through something very similar that no one else really could understand in the same way. In the beginning, I think people are sometimes overwhelmed and hesitant to reach out, and that's normal too. But I think it's a great message that at some point this could really be something that could be really helpful, and to reach out for that kind of support.
Well, thank you. So I think that's it for our time tonight. As long as I don't see any other questions that have popped up in the chat. So I want to thank everybody for being here. I want to thank all of our panelists for joining us tonight. I also want to thank our friends at Xeris Pharmaceuticals for bringing us all together here today. Thanks so much for logging on. Feel free to check out our future events at cwd.is/Screenside for more of our Screenside Chat, Sunday Screenside Chat events, and check out our website for our upcoming in-person events, our Friends for Life conferences. But thank you everyone for being here. And if you have any questions, feel free to reach out and we can point you in the right direction. Have a great night.
Thanks so
much.
Thank you.
Thank you.